Bismillahirrahmanirrahim. My name is Dr. Amber Rashid, and today my topic of presentation is malaria under supervision of Professor Dr. Saira Afzal. In this presentation, I shall be explaining the introduction, the epidemiological determinants, the chain of transmission, clinical manifestations, level of prevention, and recent advances. By the end of this presentation, the participants will be able to describe the epidemiological determinants, clinical features, national and global malarial prevention strategies. According to WHO, in year 2020, there were estimated 241 million cases of malaria worldwide. Since malaria is a life-threatening disease, so the estimated number of malarial deaths were 6 to 7,000 in 2020. And in WHO African region, disproportionately high shares of global malaria burden is present. And in region and in 2020, 95% of malaria cases and 96% of malaria deaths were in this region. And children under 5 are accounted for about 80% of malarial deaths in this region globally. In Pakistan, however, it's considered as a moderate malaria endemic country, but still there are 177 million individuals at risk of malaria. And roughly 60% of Pakistan population live in this malarial endemic regions. So this was a previous data, and there were 374,000 cases of malaria in 2018, and province-wise, among Balochistan and Khyber Pakhtunkhwa were the highest cases reported in Pakistan. So malaria, as we know, is a vector-borne disease, and it's due to the Plasmodium that has 4 main types, that is Plasmodium falciparum, vivax, ovale, and malaria. Now, this is a case study that a 67-year-old female of Western African that was presented in the emergency. And she had an history of traveling, and she returned from her travel 5 days ago. Then she started having fever and fatigue. And there was no immunization status before traveling, and patient complained that her fevers were associated with headaches, chills, rigors, and chest pains or chest pains. And patients that had on investigation, it was seen that the patient had white blood cell count of 12 with hematocrit of 10, creatinine 3, and P and Plasmodium falciparum that is missing here was seen in this slide, and patient was started with quinine 648 milligrams and doxycycline 100 milligrams IV. And the probable diagnosis was there was an index of suspicion of malaria was high because of the recently traveling to an endemic region, but there was also a suspicion of Ebola, but the final diagnosis of malaria was made for this patient. There are several age groups that are vulnerable to this malarial disease. And according to one of the studies that was published, it shows that high prevalence of malaria of age groups greater than 14 years of age is consistent with other studies that were done in Pakistan and India. And they also found out that the prevalence of malaria among females and males is higher as compared to males and among the non-immune pregnant women, and this is for Pakistan. But at global level, the most vulnerable age for malaria was under children under 5 years of age, and the most deaths accounted for children under 5 years old, that is 55%. So coming to the epidemiological determinants, for malaria, the agent, as I've already, is the Plasmodium species, and the vector is the mosquito. Economic environmental factors include economic, geoclimate, political, socio-culture, and public health interventions, and host factors are genetic and human characteristics. So the agent is the Plasmodium, and the human is the only reservoir, and the parasite are these, with these incubation periods ranging between 9 days up to 40 days. So vivax and ovale malaria tend to relapse more than 3 years after the patient's first attack, and recurrence with falciparum usually disappears within 1 to 2 years. And Plasmodium malaria has a tendency to cause prolonged low-level asymptomatic parasitemia. The seasonal variations is between July to November, and man-made malaria is due to burrows and garden pools and irrigations where the where the larvae are present, and that is the cause for the spread. So vectors of malaria in Pakistan that are is in rural areas is calciferous and stephanosis in urban areas. So malaria is caused actually it is by the parasite that is commonly transmitted by a mosquito bite. Other transmission mode of transmissions are mother to unborn child through blood transfusions and sharing needles. There are some common signs and symptoms with high-grade fever, fatigue, and rigors and chills with respiratory dry cough, and there may be enlarged spleen with nausea and vomiting. And for the falciparum, it is characterized by some high-grade fever with low blood sugar, ARDS, pulmonary edema, anemia, renal failure, and overall it is known as a black water fever. So surveillance is very important if we need to control this malaria situation and improve surveillance of malaria cases and deaths helps ministries to determine which areas and populations are most affected. And strong malaria service system also helps countries doing effective health interventions and evaluate their impacts on control programs. Like the classification of malaria cases starts with the parasitological confirmed malaria is then divided into two categories, that is due to mosquito-borne transmission and due to non-mosquito-borne transmission. And in case of mosquito-borne transmission, there is either acquired or abroad or outside areas, or acquired locally. And acquired abroad is then goes to imported, and there can be relapses like the history of Plasmodium vivax and Plasmodium ovale within the past 3 years. Whereas acquired is either introduced, that is the first generation local transmission, and or indigenous, as all cases without evidence of a direct link. So these all can go into the relapse and recurrence after the first prime infection, and not due to the mosquito-borne transmission that is induced due to blood transfusion and congenital malaria, but this cannot go into this relapsing and recurrence stage. So there are several measurements to identify the burden of this malaria, and it is divided into 3 stages, that is the pre-eradication, eradication, and there are some vector indices. So first of all, the magnitude of malaria was previously determined based on diagnosed cases, and the measurements used were spleen rate, average enlarged spleen, and parasite rate, which is that the spleen rate is actually the percentage of children between 2 to 10 years of age showing enlarged spleens, and similarly this average enlarged spleen and parasite rate, that is the percentage of children between 2 to 10 years of age showing malarial parasite. So this was in the pre-eradication. During eradication, the microscopic diagnosis became the main method of diagnosis. And the parameters used were annual parasite incidence, annual blood examination rate, annual falciparum incidence, slide positivity, and slide falciparum rate. So a brief description of each, like annual parasite incidence is actually divided by confirmed cases during the year over population under surveillance in 2000, and so on. So these were all the indices that were used in the eradication. And a malaria survey is not complete unless it includes investigation relating to these insect vectors. Some of the important vector indices are human blood index, sporozoite rate, mosquito density, man bite rate, and inoculation rate. Coming to the prevention and control, there are 3 levels of prevention, that is a primary prevention, secondary prevention, and the tertiary prevention. So for the primary prevention, there are health education, environmental modifications, and active intervention measures. So for the health education, the programs at community levels, at schools, at colleges, flyers, and symposiums all are conducted, and conferences for the raising awareness for the malarial control. So for the active intervention measures, there is a stratification of problem. That is essential features for planning and development of a sound control to strategize and maximize the available resources and provide the guide strategy to suit that more suited to that area. So there are 2 core interventions that are used for the vector control. That is the insecticide treated nets and inside residual sprays. That is now worldwide used as a vector control And according to the latest World Malaria Report, 78 countries reported mosquito resistance to at least one of the 4 commonly used insecticides. That also includes DDT that was previously used for the vector control. So these two interventions are more effective than using singly the insecticides. And in 29 countries, mosquito resistance was reported to all main insecticides classes. So this is a new problem that has been generated in the recent years. And for the immunization of vaccines, since October 2021, WHO also recommends broad use of RTS/ASO malaria vaccine. That is the trade name of Mosquirix among children living in the regions with moderate to high P. falciparum malaria transmission. The vaccine has been shown to significantly reduce malaria and deadly severe malaria among young children. Usually between 5 months to 10 years of age is the age that can be given. And due to low efficacy, the World Health Organization do not recommend these among newborn babies that are between 6 to 12 weeks of age. So the age group is 5 months to 10 years that is recommended for this vaccine among children. For the chemo prophylaxis, the recommended prevention method may be mosquito bite prevention only or mosquito bite prevention in combination with chemo prophylaxis with standard emergency treatment. So the chemo prophylaxis include intermittent preventing treatments for infants and pregnant women, seasonal malarial chemo preventive medicines, and mass drug administration. The safe and the cost-effective strategies are intended to complement the ongoing malarias, and the treatment of confirmed cases with anti-malarial medicines and prompt diagnosis is all, and along with vector control measurements is all what is an effective strategy for the control of malaria. So for the secondary prevention, there is early diagnosis and prompt treatment. Diagnosis can be made with microscopically through blood smear and fluorescent microscopy, antigen detection, serology, and molecular diagnosis with PCR or real-time PCRs. So there are two types of blood films for the malarial parasites that is diagnosed on visual basis, that is thick film to determine the parasites if present and thin films to confirm the Plasmodium species present. So currently the treatment that is used in Pakistan is for the malaria is chloroquine plus primaquine, and for falciparum it is sulfadoxine, pyrimethamine plus artesunates. So this is the treatment that is used radically in Pakistan. Artemisinin derivatives and partner medicines of ACTs should not be given as a monotherapies. Nowadays, combination therapies are a trend and monotherapies are highly discouraged. Treatment of malaria in children is immediately referral to hospital if there is serious complication and serious symptoms. If the patient is unconscious, then clearing the airway is important, and giving one of the pre-referral treatments, that is artesunate or injection artemether or quinine, administration of anticonvulsant if there is a convulsion in a child. So what are the approaches that are being used to control malaria in Pakistan? There are malaria control activities are on ground since formulation of health services provision for fundamentals outlines. In Pakistan, since it is functional since 1950s. And several failures to the several failures to the endemic countries control programs. In 1998, a rollback malaria initiative was coordinated with WHO and World Bank, and Pakistan is being signatory to the fact and started rollback malaria implementation. And under 18th Amendment, Federal Ministry along with its attached department included Directorate of Malaria Control was devolved on June 30th, 2011, and still this rollback malaria is being conducted in Pakistan. So there is a malaria control strategic plan for 2015 and 2020 with a goal to reduce 75% of this malaria with the objectives. There are 3 objectives. To achieve less than 5 APIs in high endemic areas, and to achieve 0 APIs within low endemic districts of Sindh and Punjab, with the outcomes and impacts being an annual incidence of malaria less than 5%, 5 cases per thousand, bringing down the annual incidence of malaria to less than 1 case, and at least 50% reduction of mortality of malaria by year 2020. So there are also some actions that can be taken for the protection at an individual level or for the community level. So for the individual level, the reduction of immune contact can be done by insecticide-treated nets, repellents, and for the community protection in insecticides. There is also the resource reduction and social participations. And these are all the factors that would be helpful in controlling this whole malaria problem in Pakistan with this at destruction at the source level and also at adult levels and at contact level. So there are 3 levels where there can be interventions. So rollback malaria was started in 1998 and was aimed to achieve 75% in reduction in deaths and incidents by 75%. So this was whole rollback malaria strategy for early diagnosis and prompt treatment, with including preventive strategies of insecticides, vector controls, larvicidals, prevention of malaria in pregnancies, new methods and tools, and coordinated actions through establishing partnerships, public-private partnerships. And what are the reasons why this rollback malaria is failing to achieve the goals? Is the weak WHO leadership and partnerships, wrong technical policies, lack of clear strategy, limited technical expertise, and no effective monitoring and evaluation. So what is WHO doing on global levels to eliminate malaria? Several strategies are being adopted. That includes communicating and promoting the adoption of evidence-based norms, keeping independent scores of global progress, identifying threats to malaria control and elimination as well in new areas of action. So what is malaria elimination? Actually, malaria elimination is defined as an interruption of local transmission of specified malaria parasite species in a defined geographical area as a result of deliberate activities. And continued measures to prevent re-establishment of transmission are required. So in 2020, 26 countries reported fewer than 100 cases of disease, up from 6 countries in 2000. So it has increased. And countries that have achieved at least 3 consecutive years of zero indigenous cases of malaria are eligible to apply the WHO certificate for elimination. And since 2015, 9 countries have been certified, that are Maldives, Sri Lanka, Paraguay, Uzbekistan, China, and Argentina. So there is also a WHO framework for malaria elimination. That is the WHO response against malaria was the global technical strategy for malaria, that is up to 2030, and it was recently updated in 2021. And the strategy includes the reduction of malaria cases by at least 90% by 2030. And the same is for the mortality rates. And eliminating these malaria to at least 35, now it's 26, but by 2030, it's to 35 countries, and preventing the resurgence of malaria in all countries that are malaria free. That are 9 countries already. So this strategy actually provides a comprehensive framework and emphasizes on the needs of universal coverage of core malaria interventions and high quality surveillance data with decision making and policy making, and keeping the cost and in mind. And the WHO actually strategy was developed in close alignment with this rollback malaria partnership, and to make the malaria free world with achieving the goals by 2030. So the principles for all countries can accelerate their efforts towards elimination of this malaria with country ownership and leadership, improved surveillance, equity of access to services, and innovation in tools and implementations. So this was the whole framework with the supporting elements and pillars that were explained, like accelerating efforts, transforming malaria surveillance, and ensuring universal access. With several components that the description has been given below, and going towards the high malaria cases to the low achieving the zero level and then maintaining this zero level where you can document the elimination and maintain. So it is all based on investigation and population-wide parasite clearance, increased sensitivity and specificity of surveillance, and enhance optimized vector control. There is also a malaria eliminating a program run by WHO with community settings and independent scores for global progress in developing approaches for capacity building and strengthening the system and surveillance. So this is the whole framework, and this is from 2016 to 2030 with the pillars of similar to that framework previously explained, and having the three pillars and then going to the strengthening of enabling the environment to control this malaria problem. So it is then now targeted that by 2020, the mortality and the cases more than 40%, but by 2025 it would be 75, and by 30 we would be able to achieve by 90%. And also to eliminate malaria and prevent re-establishment of malaria in at least 35 countries. Now we have 10 countries, but by 2025 it's a target of 20, and then 35 is the final target by 2030. So now it's time for some recent updates. This was the paper that was recently published showing the chloroquine resistance Plasmodium falciparum in Pakistan. And the reasons that were identified in this paper that the poor and presumptive diagnosis by an untrained laboratory personnels, misdiagnosed falciparum is one of the reasons, with improper medication, migration of Afghan refugees, massive amount of agricultural land available that can breed mosquito sites. And due to all these factors, Pakistan seems to be entering an age of advanced drug resistance, of which is where monotherapies are not enough. And policymakers should consider this overlooked pattern of malaria, and otherwise malaria will become deadly in Pakistan. There was another paper with geospatial clustering and hotspot detection of malaria in Bahawalpur district. And the key purpose was to measure the spatial patterns that are helpful in gathering local environment epidemiological hypothesis for malaria. And results showed hotspots, high hotspots and low hotspots clusters all over the district. And the local environment issues and minimizing the incidence malaria through administration of environmental management community participation was essential. And further research must be applied to identify more hotspot areas in this endemic malaria district. So last was the mapping of genetic markers of artemisinin resistance, and it was a systematic review. And this showed that there is a specific gene marker that WHO validated, that is the K3 marker, and a CYS580 TYR mutation is the main region which is causing this resistance against many individuals. And more research is needed so that the policymakers can take this point under consideration. So now it's time for the MCQs. First MCQ is the malaria is an endemic in many countries and reported to be leading cause of death for parasite infection, killing millions of people globally. The greatest deaths occurring in Africa. Which of the age group is the highest death rate that has been globally addressed? Either it's 10 to 15 years of age, less than 5 years of age, more than 40 years of age, or 10 to 25 years of age. Any guess?
A.
Yes, A is the right answer. Between 10 to 15 years of age, the right answer. Which of the following statements regarding prevention of malaria is true? A combination of preventive measures is most effective. DDT is still commonly used. Low-tech preventives like nets rarely affect limiting bites, and preventing measures are not very effective in case of falciparum.
A.
Yes, A is the right answer. The combination is the now the key for the preventive measure for that is most effective. All of the following statements regarding recurrent malaria are correct, except some patients develop malaria again after a period. Recurrence is due to insufficient treatment, relapse due to appearance of morozoites. It can be seen in all species of malaria. The highest rate of relapses occurs against P. vivax. which is not correct.
D.
C is
D.
C is
C.
not correct. Yes, C is not correct, as it is not present in all forms of species malaria. So a person developed the infection with P. falciparum, and the complications were hemolytic anemia, jaundice, discoloration of urine. Which of the following terms is applied for this type of complicated disease by P. falciparum? That is Rift Valley, yellow fever, black water, or Kala Azar?
C.
Yes, it's black water.
C.
The malaria during drug hydroxychloroquine was falsely reported to be effective in which of the viral type of infection in 2020? Either it was dengue, it was influenza, it was COVID-19, it was swine flu, or it's hepatitis.
COVID-19.
Yes, it's COVID-19. That it was misinterpreted that hydroxychloroquine is effective against patients in COVID-19, and trials were also done. In 2021, WHO has recommended the first ever vaccine against malaria. Which of the following age groups can get the dose of vaccine who are living in endemic age? Children 5 months to 10 years, 15 years or older, 60 years, or infants only? That can be given.
B.
Can be given. That can be given.
A.
But yes, the age group is 5 months to 10 years. That is recommended by WHO for children living in endemic or epidemic regions of malaria. Thin blood smear film for malarial parasites is used to determine the malarial parasite present, to confirm the Plasmodium species, malarial parasite absence, malarial parasite present, and confirmation of Plasmodium species.
B.
B is the right answer to confirm the Plasmodium species. 8 is which of the following symptoms are most common in people who are infected with malaria? Muscle aches, low grade fever, skin rash, swollen legs and hands, mouth rash, itchy skin, high grade fever with chills.
D.
Yes, chills is D is the right answer. And giving this MCQ, there was a base that there is also an Ebola infection, but chills are absent with high grade fever. So presence of chills is an indication of malaria. So D is the right answer. What is the most common treatment that is given to uncomplicated falciparum malaria in adults, excluding the pregnant women? Either it's chloroquine, primaquine, sulfadoxine, pyrimethamine, artesunate combination, or quinine dihydrochloride?
C.
Yes, C is the right
D.
option. Here, the purpose of giving this MCQ is that the combination medicine is the trend rather than a monotherapy that have been considered obsolete. And last is the development of malaria vaccine has faced several obstacles. The lack of traditional markets, developers, and complexities against parasite was one of the challenges. So vaccination against malaria is not successful because it does not produce antibodies or antitoxins. Plasmodium produce minute bodies, Plasmodium produce antitoxins, and Plasmodium virus is vulnerable to heat.
B.
Actually, it's A, that it does not produce any antibodies, antitoxins. So this is one of the main reasons why the vaccination against malaria is not very successful. So it is the key. And thank you.
Thank you very much, Dr. Amber. Very nice presentation and always